much. And I think this talk will be a little different from the one you heard before, the ones you heard before, because I want to give you a glimpse into the practical daily activities in the genetic clinics. I think that I will echo some of the talks that were given before, and maybe we'll wrap up whatever you heard. I would like to emphasize a few things. First of all, Israel is a small country, 9 million people according to the last report, but still very, very heterogeneous. We have a lot of, we have diverse population, we have different ethnic groups here, and also there are a lot of differences between I would say, cultural background of the people, and we have ultra-Orthodox religious population, both Muslim and Jewish, and we have to the other spectrum, other side of the spectrum, secular, totally secular, liberal population, and we have the whole between population in the spectrum. And then the Israeli genetic counselors and geneticists act according to two Israeli laws. One is the one you heard before, is the Act of Patients' Rights, of course, but there is a specific act of genetic data from the year 2000, and we have to act according to this law too. So in light of the fact that you all know about the uniqueness of the genetic data, in our daily practice in the clinic, one of our first mission is to inform the people in our room, it might be one individual, it might be a family, about all these pieces of trivial data for you that many of the general population is unaware of. What the genetic information, why genetic information is so special, why we deal with it in a specific context, and one of the important information, as you heard from Tzivia, is the ramifications, the implications for other family members. And in this regard, genetic data is totally different from other medical data that people might face along the years. What is genetic counseling? And not only the patients, but only many of our colleague doctors are not properly familiar what it is all about. So I will go on with you along the slides, saying that it's a process of providing individuals and families with information on nature, inheritance, and implications of genetic disorders, and now some very crucial points to help them to make informed medical and personal decisions. And it might heard very, very easy to some ears here or elsewhere. Just to tell you from my own experience, it's sometimes very, very hard, because the people we meet, the people we care for, come from all kinds of backgrounds, educational and other backgrounds. It's not easy to deal with genetic data nowadays. Many of them will not think about other implications, ramifications, including ethicals and morals and others. And if we will not draw their attention to specific potential hazards, they will not think about it. Understanding the research, the scientific data behind the information, the test results that we will deliver might be very, very complex, might be very and not easy task at all. And again, I would say sometimes to my colleague, when I discuss things, I find it's very, very challenging, let alone to the general population, which for most is ignorant when it comes to genetics. What I would like you to do is what I do whenever I talk to students and tell them that, in particular in genetics or genetic counselors, and ask them that unlike in the general aspects of what we teach them and expect them to be professionals, when I speak about ethical aspects of genetic data, I want them to be non-professional. I want them to think about the people they care, the people they love. And then they'll come out with a general decision, general conclusion, general views over the ethical aspects that should dictate our work in the clinic. Because only if you think about people you love, like your parents, like your children, brothers and sisters, everybody has somebody to care for. Only in that situation you can grasp the complexity of the situation that we face, again, on a daily basis. So let me just share with you some slides discussing all kinds of examples that tomorrow, when I get back to my office and I have to deal with my stuff, this, for sure, some of these aspects will come up and I have to deal with. So unlike the many populations in the Western world, of course, in Israel we do a lot of perinatal practice, genetic tests and counseling. And maybe excluding the Orthodox population, most of the population, including what we call here traditional, Masortiim, and religious people will want genetic intervention, genetic tests, and other active steps along and around pregnancy and along the pregnancy. And we here try to follow the current ethical principles that guide the practice of genetic counseling in the Western world, like our colleagues. And that means that the genetic counseling should be non-directive. So it's more complex than that. Of course, we do say what we think. We do speak about odds. We do speak about risks and what are the consequence recommendations of ours. But still, we never say, like it might be echoed from the previous talk, do that, do that. We totally respect patients' autonomy, and please don't think lightly about this point, because in Israel we have many societies that autonomy is not one of the top most valued principle. Most of the people in these communities do not feel autonomous for themselves. They will consult with a rabbi, with a Qadi, with the old people in the family. I don't know, but they are not autonomous. And they find it hard to struggle the challenges that we put on the table. So there is no genetic counselor in Israel that will not hear at least once a day, Doctor or Mrs. So-and-so, what would you do in my condition? What would be your, if I were you, what would you do? Of course, we have to make sure that individual human rights overweigh any society interests like everywhere else. And I can tell you here as an Israeli that it didn't happen once, it didn't happen twice, that I had to talk to decision makers in the health system in Israel and tell them that their idea to make people sign of a paper saying that they will do a prenatal test only if they give their word that if the fetus is affected they will terminate the pregnancy, that I think that such a paper is not acceptable, and it's something that we should go along these lines. It didn't happen once. It didn't happen twice. That means that people, and they are not stupid and they are not bad people, but somehow if you put together money and health system and you're not very well aware of the ethical issues that the people in this room found very, even trivial, something that you have to have in mind always. So the sad situation is not, this is not the situation. And many people do not have this view, do not have the tools to look 5-6 steps ahead about their suggestions. Of course, we have to respect and honor genetic diversity. Of course, we have to avoid designing personal features and behavioral characteristics, and this put us sometimes in a very, very charged situation, because the general population, at least in Israel, is very active, is very, read a lot. There are very people aware of genetic tests and what genetic tests can lead you to, and they are very, very interested in such information, often. And they are very surprised to hear that such tests on a daily basis are not available, or at least deserve a second thought. And of course, we are not intend to intervene with a human genetic pool, but saying those words and speaking about all the things that you heard this morning, I will ask you, theoretically, what would you do if you face couples that would like to deal with prenatal diagnosis in terms of prevention, because this is what we can do nowadays, for a deaf baby? So in Israel, just to share it with you, in large extent, this is something that is considered acceptable. Unlike in many, many communities in the States that regard this issue totally different. And what about FMF? FMF, it's an autosomal recessive disorder, very, very common in Israel in many, many ethnic groups. This is a treatable disorder associated by spells, by recurrent events of fever and stomach and aches and pains in your stomach, sometimes in your chest. And there are, as I said, there are very, very effective medications for this situation, but it's a lifelong disease. You have to take medications all your life. And I have not encountered with parents who ask for prenatal diagnosis, but I know of colleagues of mine that did have to challenge this issue. Would you do prenatal diagnosis? Would you give hand to terminate a pregnancy of a child affected with FMF? What about mild or cosmetic problems? So let's speak about cleft lip. So on one hand, of course, you can present it as an only cosmetic problem, but from the parents' point of view and the family point of view, it's far away from only cosmetic problem. It's something you see, it's something that many people will find repulsive in a way. It might affect the bonding between a baby and the mother. And as a geneticist, I can tell you that once we diagnose using ultrasound a fetus affected with cleft lip, I know that these fetuses' chances of having other genetic medical problems is higher, because it might be isolated, but it might be a feature of a wide genetic syndrome associated with other problems, such as intellectual disability. And of course, ultrasound cannot diagnose intellectual disability. Okay? So the gray is not that gray anymore, right? It's not that black and white anymore. The gray is very gray this morning. How about fetal gender selection? In Israel, this is something that is very, very important and central, I would say, in prenatal world. So we just spoke about how social event it has become to have the ultrasound, and nowadays which is actually a medical examination. And the young generation, when I tell them that a generation ago, a generation and a half ago, people did not know what is the gender. Mothers did not know what gender the fetus will be, only at the time that they got to the delivery room and gave birth to the baby. Then they knew that they have a girl or a boy. So today it sounds unheard of, okay? It sounds like, wow, you were primitive these days? Yeah, we were. And now making a genetic test to know whether the fetus or any individual is a male or female is the simplest test in the book. So if you can do that, you the doctors, why don't you use it to help me design my family according to our wishes. And let me share with you something, my sisters in the room. In Israel, the more desirable gender is not ours, if to speak in a very,
like China and India.
China and India. But this is Israel. We regard ourselves as a very advanced, liberal, country. So, not in this regard. And of course, we are not there, but it will not be far away from us that very simple laboratory tests to know what would be the prospect height of a fetus, IQ, and other personal traits will be available, and people for sure will ask it during pregnancy. How about pre-symptomatic genetic conditions? So you heard about cancer. We have many tests now that if we find an abnormal result, we know that the individual is predisposed to having cancer. So I would like to make here, to end here, another information that will make our complex picture even more complex. So for the most of these tests, like BRCA1 and 2, most of you must have heard of, the test will not tell you for 100% if you'll get cancer, yes or no. It will talk about your predisposition of having cancer. So in this regard, do we want to test for adult diseases, cancer included? But I gave here the example of Huntington's chorea. This is a devastating disease, developing around the age of 40 years, with a severe deterioration in the cognitive abilities, and also all kinds of neurological manifestations, including spontaneous, very, very hard to see movements. And it ends, of course, with premature death. So we don't have anything to prevent, any medication to treat this disorder or to change the course. But a person who is at age 30, let's say, does he or she deserve to know that they are going to develop this disease in so-and-so years to come? And what can they do about it? Well, they can. They can prepare themselves, they can make all kinds of insurances, they can prepare the family, and so forth. And what else? What about the next generation? So the mother would like to test the prospect fetus for Huntington's chorea, but the spouse, the father, who is in his family, the disease is diagnosed, he doesn't want to know. He doesn't want to know about himself. He doesn't want to be tested. And if you test the fetus and you find the fetus to be affected, that means that the father now knows what his genetic condition. Should we test or not? We do lots of general screening tests in the population. In Israel, we have many, many programs. Everybody here who was pregnant in the last years or so cannot not understand what I'm talking about. We have started with Tay-Sachs, which is very prevalent among Ashkenazi Jewish population, but now we have a battery of dozens and dozens of different diseases that we can test because we have diagnosed them and found them to be relatively frequent in specific populations. So keeping personal autonomy in these projects is very, very difficult because we speak about mass screening. And in Israel, we still request an informed consent. But what will be the informed consent process in such a situation when everybody is being tested? How come you don't want to be tested for Tay-Sachs? It's a devastating disease. How really the informed consent is informed? And then let me take you one step to where I work in Afula, which is a northern part of Israel. We test large population of minorities. And in the minorities, mainly in the northern part of the country, in each town, we used to call it village, but most of them are really towns, they were founded by a very small number of families. And if you tell me a family name of an Arabic person from the north part of the country, I know in what town he or she lives in, because people used to marry within families, within their towns, and of course they have their own diseases, recessive diseases, that are more frequent in a specific town and not in that town. So telling doctors, let alone the general population, what diseases are diagnosed in a town called Iksal, next to me in Afula, is like revealing personal data, because there are certain families, large families, Hamulas, that live in Iksal. And speaking about Iksal, or the name of the Hamula in terms of these diseases that are frequent there, is practically the same. And how about screening the whole population for diseases that are about to develop, to show themselves later in life? We spoke about cancer. The genes BRCA1 or 2 are associated with breast cancer. And many of my colleagues think that if you take into account the prevalence of mutations in the genes in the population, in particular the Ashkenazi Jewish population, the preventive measures that you can take nowadays in terms to improve the outcome of the cancer with the early diagnosis and so forth, they are confident that it is advisable to perform the whole population screening at a younger age for diagnosis those who are carrying mutations in these genes. And of course, tests in children have their own specific issues that must be addressed. It has been discussed in a previous talk quite extensively, so I will not go over it. And by just talk about pre-gestational genetic diagnosis, a new technology that is widely practiced here in Israel for prenatal diagnosis. So it's kind of a diagnosis prior to pregnancy in the lay people language. So to speak, what we do IVF, we do in vitro fertilization, we do fertilization of an egg in the laboratory for reproduction. And then we have a very, very small fetus. In English, we call it embryo. In Hebrew, we have only the word ubar. So when I speak ubar, I don't mean a very little baby lying in a tube, okay? I speak embryo. I speak a few cells of future to be a human being. And if you take one cell out of this 8 or 16 cells embryo, you can test everything. You heard that we can do a whole exome sequencing nowadays from one cell. What we do on a daily basis is testing something that we know of, a disease that was diagnosed in the family. And this is prior to pregnancy to avoid the need of prenatal diagnosis and termination of pregnancy. Now I get back to the simplest test in the laboratory, genetic test. I mean, testing the gender. Should we allow PGD for sex selections? And then, of course, other very complex issues of the era when we do a lot of high throughput genetic tests. You heard about exome sequencing and whole genome sequencing. So we do it on a daily basis. And it's a matter of huge headache for us, but also for the individuals in our counseling room that have to deal with medical information that they didn't think of, they didn't intend even to hear about. Of course, we discussed it with them prior to the test. What is their view about those incidental findings? But here we have our professional societies saying, if you find something incidental, which is actionable, like many genes associated with cancer, you are obliged to share it with your counselee. And I can tell you again, think about you. Think about people you know and love. and their ability and their emotional situation when they have to deal with such a situation. And let me finish with I would say, how many I put here? Five examples of, challenging situations in genetic clinic, just for you to think about it. First of all, to feel some warm feelings to us, to me personally, and then to think about the price we have to pay in our era when the technology is so advanced, and we want to translate it to daily medical practice. But there are some things to think about and to implement in order to do it the right way, if there is something called right way. So we heard about the disclosing genetic tests to other family members. You have to remember that in Israel we have many, many societies that knowing that a person, namely a woman, is a carrier of a genetic situation, a genetic abnormality, making her predisposed to some medical condition, or worse, predisposing her children to be affected with medical situations that make her, in some societies in Israel, a person of second degree. And she might be severely discriminated when it comes to marriage, when it comes to her chances to get married at all, and if so, who is the spouse that in those usually conservative societies will be matched with her. And this is across religions here in Israel. It's not rarely that we face a couple that do not agree what they have to do with their future pregnancy or the ongoing pregnancy. Think about something that is autosomal dominant, that will pass from a parent to a child. One spouse is affected, the other one is not. So we had all the combinations you can think of, that the affected individual said, I don't want children like me. I don't want to have children like me. I want prenatal diagnosis and termination of my child that might have a condition like me. And the other one will say, no, I love you, I married you. Why should I terminate a child that will have the same condition as you? Now think about the other condition in which the affected individual will say, I don't mind having, if you were to terminate my pregnancy, me as a fetus, I wouldn't be here at all, right? And the spouse would say, no, I don't want to cope with a child affected with it. Okay? So, yeah. Not always, though. So just to give you a hint or to taste what it's like to sit in the genetic clinic nowadays and to use all the benefits the science afford us in order to make our patients happier, healthier, and hopefully we do it to some extent. Thank you very much.